Well, welcome everybody, and thank you very much for asking me back. So my name's Wal Grimmett. I'm an anaesthesiologist in Australia, although they're called anaesthetists over here, but I'll stick with anaesthesiologist to avoid just confusion. So my background is I've done a lot of that in the past, just at aeromedical evacs with helicopters. I've also done a fair amount in military as well. And for Lawrence, that's a C-17. Yes, it is a very cool aircraft. The I also do a bit of teaching of medical students, and so that's the inevitable result of my teaching. I guess Nancy knows about that. And now I do anaesthesiology, and I do have my coffee here this morning, which is this afternoon. I've always been interested in patient safety. In 2012, I had the honour, I served with the US Navy in Afghanistan, but a pilot friend of mine, I said, oh, you need to read this. And so that's what I took a whole lot of other books, obviously, but this was one that fascinated me when I was over there, and that was with Eric Nagel, David Woods, and of course Nancy Leverson at the bottom there. And the history with that is I was fascinated by FRAM, and I love the language and the concepts, and we began to do a few talks in Australia over here, just at a local level down in Brisbane. And there's a few people who are really quite interested in exploring. It got to the point that, hey, we've had this problem with a tourniquet, and I did this one in the last talk I did. We want you to use FRAM to investigate a tourniquet event. And then I sat down, I thought, great. And I looked at it again and I thought, I can't do it. I don't know how to make FRAM work in a practical sense. And part of it was there's a lot of reasons for that, but part of it was just resources. And it wasn't for lack of trying. I've met Eric Nagel. I've been to his master's course. I've been to his other courses as well. But in terms of sitting down and doing something like this, where a leg has essentially died from a tourniquet event, I couldn't actually model it. So, and that's the reason why we've all seen these models. And it wasn't so much that I thought with enough time I could make it work, but how the heck was I going to communicate it afterwards? How was I going to explain to everybody my logic to the conclusions I've come to? And I began to realize that'd take another month of lectures just to get the logic across. So I went back to CAST, and that was its ease of use, special reference, particularly the training burden to investigators. The resources were required with reference to the number of personnel. You can do it with a very small number of personnel. Time required, it is more. In the previous talk, I went through all the times and documentation and costs. It seems about double an RCA, but I could communicate the model, and particularly communicating my ideas and the logic to hospital and legal positions, and particularly people such as coroners and that. The other thing, it was relatively easily to integrate into a current quality and safety system. There's a lot of similarities in the initial stages of the investigation between doing an RCA, which Australia's very big on, where RCAs and bow tie diagrams in fault tree analysis, etc. All the other stuff essentially unheard of. Now, when I gave the last talk, I went through all the experience from the first 5 cases of investigations and what I'd sort of learned. What I was dying to talk about was these two, because I was actually doing 2 other investigations at the same time. But and they really demonstrated some things that I just simply couldn't talk about because I didn't have legal permission. So in Australia, the way I'm working at the moment, and it's pretty unique, is that I'm actually paid by the lawyers. So everything's medical, legal, in confidence. And so I have to get the lawyers' permission to discuss all these cases. But here's the beauty of it, and I don't know how this has happened. The lawyers are great. They've been incredibly cooperative. They want to see just results from investigations. So, and they're very process driven. So they concentrate on the process, which is what we're not, just not the end results. But there's basically, I believe there's one anesthesiologist in the room, Aubrey. Essentially, this was a dental anaesthetic case where it's commonly around the world, you get a bit of gauze and you shove it down the back of the kid's throat, and it sounds brutal, but that's essentially what it is, after you put tubes down and everything. And the idea is the dentist makes a mess, there's pieces of teeth and blood and chips of bone and things go down. that bit of gauze or throat pack catches all that, you pull it out of the end, and all the bad things that are going to happen are gone. And it's a doctrine and dogma in anesthesiology, and I choose those words deliberately. Okay. The other thing it described is that in medicine, all the controls are hidden. Even the people in the room in this event didn't know what was actually happening and how they're actually working. It takes a long time to find out through interviews how the room is actually working from a systems perspective. They have operating procedures, but they're rarely ever followed because they're trying to make variations to actually get the work done. So to actually find the controls is actually quite hard. And particularly in medicine, that's what I'm finding. And basically, this case demonstrated there's a wide variety and variation in mental models in the same room amongst operators who often work together. And you have to work at your interviews to get each person's mental model out. And that's what I began to learn during this case, and that was different from other cases. The other thing is there's this amazing cognitive loading effect in terms of human factors, which is a separate topic. It's sort of outside what we're doing, but it certainly demonstrated it beautifully in Zayo's paper years ago on the effects of cognitive loading in anesthesiology came up. And this is like your typical RCA initial timeline, but it works well in CAST, I'm finding as well. You simply map out exactly what's going on. And as you can see, the anaesthetic was an hour and a half dental anaesthetic, roughly. It's not too bad. Everything went pretty well hunky-dory. All the disaster happened in the last 6 minutes. And what was that? Was that basically it was an induction, but there was the primary scout in the theatre, and there's a scout reliever. Then the primary scout came back, and there's a primary anaesthetic nurse and an anaesthetic reliever, and then the anaesthetic nurse came back. But hidden in this is the detail. The anaesthesiologist came into the room, and that was the first time she'd worked in that room. In fact, it was, and she wasn't the normal anaesthesiologist of that team. She was very good. She's a paediatric anaesthesiologist. She worked at the Children's Hospital. She hadn't worked in that theatre before. And here's the thing, the hospital was losing money doing dental anaesthesia. It was keeping it going because there's nowhere else for these kids to be done. So it's okay, we'll take a loss. So there's a lot of economic pressures on this place as well. So they'd set up an isolated dental anaesthetic unit upstairs away from another theatre block with an isolated post-op care unit as well. So suddenly you see a scenario growing, which is heading towards disaster. And you could look at Swiss cheese models for that as well. You could create an event, but I don't think you would have got the same result I got by using CAST, what I end up with here. Now, the dentist then said to the anaesthetist, you're responsible for putting the throat pack in, you're responsible for pulling it out. I don't want to hear about it. Okay, that changed all the routine for every other dentist in the hospital. All the others, the dentist pulled it out, the anaesthetist put it in, or anesthesiologist put it in. So come to the end of the case, and tea relief arrived. Now, so the anaesthetic nurse, you might forget relief for tea, no problems, you duck out. I'll be back before the case finished. Case finishes early. So there was an anaesthetic reliever. Now the scout nurse changed over at the same time as well. Now she noticed the previous way that other scout nurse had written stuff on the board was all wrong. She began to re-document all that. And she noted there was no throat pack written up there, but she thought, oh, that's the way they do it, stuff like that. Bottom line is, end of the case, the anaesthesiologist pulled the tube out, kid looked fine, went out to the post-anaesthetic care unit, child came close to respiratory arrest, re-intubated, found a throat pack. And you sort of think, from an RCA perspective, easy. You would basically say an anaesthesiologist should have remembered to remove the throat pack. All these procedures and protocols were broken. Things weren't documented properly. Checklists weren't done properly. All that sort of stuff. And you sort of think, yeah, that's all true. But what's really going on? And because the anaesthesiologist is not dumb. And the anaesthetic nurse didn't deliberately leave the throat pack in either. And she was knocking herself up. We simply forgot to pull it out. How terrible are we? And then she was in tears during the case. But what's actually happening, and this is where I find CAST incredibly useful. As an anaesthesiologist, I'm looking after an airway, okay? And I do actions to that airway, and those actions are based on what feedback I'm getting back from that airway. And that is basically, what have I got? I've got the colour of the patient, I've got chest movement, levels of consciousness, I've got sounds and noises coming from that airway, I've got saturations from pulse oximetry, and I've got end-tidal carbon dioxide, what people are breathing out and things like that. All very useful. But what happens if I get a little airway hazard and I shove it down the back of the throat and hide it so nobody can see it? Okay, so what actually happens to my feedback loops? Well, nothing. None of them are going to work. And not only that, so let's go back to originally what control loops are. What are the features of control loops? Well, they have to be present. I need a control that's going to be present. Okay, it needs to be correct. The feedback. It needs to be the feedback needs to be it needs to be present. Needs to be correct. It needs to be correctly timed, and it needs to be of the correct duration. That's basic. So look, okay, of all those feedback things, can any of them work? No, they can't. It's impossible. So we create a scenario which is impossible for the anesthesiologist to reliably get adequate feedback to detect that a hazard's present. So the only thing he can do that I could think of, if you routinely got a big steel blade called a laryngoscope, put it down the back of the kid's throat and had a look. Okay, that's the only thing you could physically do that would be reliable, that would meet those control feedback things. So that was the first thing I came up with. But they said, oh, they've broken all these protocols and they've all these all these other things they should have done. They should have had stickers. They should have had things on the whiteboard. They should have had, it should have been documented on the charts. It should have been all this. And all that is true. It should have been. But they are memory aids. Okay, so okay, how do memory aids work? Well, they have to be initiated by somebody, and then they have to be accurately recalled. But the trouble is they're all fallible. So the throat pack present should have been written on the whiteboard. But the first nurse thought of that. I don't do that routinely because it's written on the count sheet anyway. But where it's on the count sheet is outside the normal part of the count sheet. So the count people doing the counts think that's not part of our count. That's part of the anaesthetic count. So, and everybody's mental model was totally different about how the same system was working. And this place had been working routinely for a year. Okay. And so what CAST did, it dragged me back to what was actually happening. So we got fallible memory aids. So I can say, yeah, remember more and be more vigilant is what I could have said. Singly the most useless thing you can actually comment on out of an investigation. And even Queensland Health and the legislation says, don't ever do that. So it really just came back. There are no feedback observations and there's no aids that can can guarantee that this won't happen again. It's going to happen again. I can't guarantee it. There's very few system changes that I can make. And here's the thing is that RCA would have led me to hammer those memory aids. They're not going to work. CAST said, what system changes can I make? And it's basically saying there are very few, if any, you can actually make in this situation. So what it actually said was, okay, well, that's that control thing in terms of correct duration. It reminded me to talk about it, so we'll skip that. But here's the other thing. Is that other thing people have been thinking about this around the world as well, you know? And basically, why do you put throat packs down? Okay. In actual fact, there's no, as I said, it's dogma or doctrine. There's no evidence that throat packs do any benefit for the patient at all worldwide, but blooming heck, they've killed a few. And there's lots of deaths associated with throat packs around the world. And so you go back to the mental models again, and one of the girls was South Korea. And she was the one who was nearly in tears saying, we forgot to take it out. I said, where have you trained before? South Korea. How many years? 10 years. Experienced anaesthetic nurse. What do they do in South Korea? So we don't use them. We simply don't use them. It'd be, we'd be seen as ridiculous. It's an Australian thing, she said. She thought it was really weird when I came to Australia. Okay. So the systems change suggestions, which CAST led me to, was routine direct laryngoscopy. It was the only feedback loop I could add that could probably work. If you did it all the time, you're going to pick it up. I thought, okay, if they're going to use throat packs anyway, and they're going to be retained, what's the safest place they can be retained in? Well, probably theatre. Don't have two anesthesiologists putting the next patient asleep while the kid's choking to death from a throat pack in the PACU. Just seemed a bad idea. So let's just do all the extubations in theatre with the child fully awake. So at least we might have a chance of getting some feedback earlier. Because the kid's going to pick this up themselves anyway. But the trouble is the way they're going to pick it up is they're going to have a respiratory arrest. Okay. And people are going to notice that the child's not breathing and dying. That tends to be thinking. So all this is about how to get this throat pack out before the endotracheal tube comes out. Okay. Okay. So the other thing is eliminate throat pack use entirely. And the other one was redesign a throat pack. And you could change the documentation. That was an obvious thing you could sort of do. Now, put it up as suggestions, because here's the thing that I love about some of the language. Intractable is that I was only in there for 20 hours doing this investigation. I still don't fully know their system. They know it better than me. So what I can do is make suggestions to changes that I saw in an investigation, but they have to make those suggestions work within their system. Okay. And they're probably a better judge of that, I think. So I put it as suggestions. Okay, the other one that was totally different, I'd never done before, and I thought, how do you make CAST work in this? Was I got a letter from the hospital saying, look, we've got a bit of a problem. We've got this letter from the coroner. Do you think you've got it? Do you think you'd want to have a look at this? And my immediate response was, oh, yes, it sounds fascinating. And this is the letter from the coroner. It says, my investigation has been informed by advice from an independent doctor from Department of X, who's reviewed the record from X and X hospitals. The reviewing doctor has raised concerns regarding Mr. X's discharge. Considered as if it had not been discharged, he may not have died. Okay, so yeah, they've got a major problem. Okay, they're saying they discharged him too early. And the reviewer also raised concerns regarding the lack of documentation surrounding the case. So what it actually, so go into this little thing, so I'll set up a CAST investigation. So that's how I start. And the hospital said, we'll send you all the information. So they sent me 190 pages of randomly presented data from the electronic medical record system. And I said, is this exactly what you sent to the coroner? He said, this is exactly what I sent to the coroner. It's all there. I said, fantastic. I spent 10 hours trolling through 109 pages trying to get a timeline, okay? And all the data for this treatment of this patient was there, and it was correct, and it was perfect, okay? And what wasn't there was that it took 10 hours it was all hidden in this total disorganized noise. And I basically said, well, I'm trying to work out how this would fit into a car system and what models I'd have to draw, and I was going to spend hours drawing control loops and everything. And then I thought, well, you know what, I don't have to. Nancy's already done all this for me. It's to try and communicate this result is that I can just get a generic CAST control diagram. I've got a government regulatory agency, I've got a company, which is the hospital, and I've got adverse coronial finding. And the reason I've got that is the accident incident report is a total disaster. Okay. And then so 4.5 pages report was simply saying, these are all the reasons why the coroner didn't look at your case. Because the treatment was actually perfect. It was all there, it was all documented. It was just randomly arranged. So it was just a totally different problem. And a totally different way of looking at it. And they've gone back to simply reorganize the electronic medical record system as a result. Because the problem wasn't the problem. They thought the problem was the treatment of the patient. The problem was the way they presented the data to a regulatory agency. So it was an interesting way. So what I learned is the problem needing investigation is not always clear when you start. And generic control loops can save you lots and lots of time and communication. I still need a psychology degree. I think people picked up on that. Here's the other thing. I'm still not getting feedback, but the feedback I am getting is from all those people who are crying is we are doing it. There's a big issue with second victim harm here. One of the nurses I interviewed over a year ago hasn't worked again. She's a good nurse, and it just simply hasn't worked. And I thought, okay, well, how am I going to get a study up arranged on this? But essentially, admin, lawyers, staff, everybody is on the same boat. They also, we really need to look at this. So it directed me to another psychology research project looking at second victim harm from investigative incidents. So the other thing that I was really coming up was that there are a lot of generic studies out there. Throat packs are going to be retained all over America. Okay, they might not always reported they're going to be happening. So would pooling of our investigations and findings allow us to save duplicating some of our efforts? In particular, retained throat pack is going to be happening everywhere. The control models could be easily done by anybody, those sort of simple control models. John's doing at the moment, looking at pain. You're doing the STPA analysis, I believe, on pains, and that involves pumps. One of the cases I investigated, the pump actually was known to be faulty. It didn't cause the event I investigated, but it would have mimicked it exactly. The FDA already knew about it. Our TGA equivalent already knew about it. But the control stuff and everything that John's doing could have easily put into my investigation. So are we creating too much work for ourselves by not being able to pool some of our data? And that's something just for the audience today. But here's the other bizarre thing. The legal guy came back and said, I get it. I finally get it. Okay. And I thought, why? Why do you suddenly get it? You've had 5 cases. Why do you suddenly get these? And I think one of the things I'd like to put to the audience is, are we creating too many problems for ourselves? This is what an outside audience is seeing. And we used to say, and that's what we tend to be, they tend to be looking at that. We want them to look at that sort of stuff. We're stuck here and we've got bow ties and rules. And that's what the outside observers are really looking at. We've got this huge choice. We want them to go, they've got that huge choice outlined in the dream, sorry. We want them to go here in terms of their thinking, but we're saying that's the one that's correct. I think I'm shooting myself in the foot. Currently, I'm moving into another organisation and they're saying, yeah, STAMP's good, but we need another model that's more medical specific. But Nancy was saying at the last meeting, I spent 35 years trying to get into medicine and I can't get any penetration. I can't get some leeway. So if we start presenting another model within STAMP, and I haven't even looked at EastBN and EastBL, and I have a little bit of look at FRAM, maybe we need, as a group, need to be concentrating. We need to look at all the models in terms of class and start using that and start getting some penetration in terms of quality and safety for that. I mean, and Stanton talked about this in terms of the various models. He did a great paper. He just compared them all. I'll pull out one of his things. Here's one of the problems. This came out. Oh, I forget the paper now. There's 106 different STS-based methods being identified at the moment. So that's what people are looking at. So maybe we need to get people to be focusing, and this is Stanton's diagram, on systematic methods rather than cognitive methods. Move on and move everybody towards either STAMP, CAST, FRAM. Because part of the problem that's happening is we're trying to communicate all this is our communication is causing some harm. And Decker put this article, he just published it online through Griffiths, it's not peer reviewed, but he basically showed that the communication story that we give has profound impact on the actions by people outside. And I thought it was interesting that we can start causing the language we use and the way we can communicate affects the actions of the people we're making these reports to. So we've got a responsibility to make sure that everybody's on the same page. And I'm just thinking, maybe we should go back to this, is that, which is Nancy's, that 2004 article, and I always bring it up. FRAM, EastBL, EastBN, and STAMP all do this. I think it's the gold standard for models. Now, I don't want to go back to that. Don't get me wrong. That's horrible. I don't have the time. I don't have the resources. I probably don't have the brain power. But I say I'm using a systematic method of investigation looking at complex systems. My choice in this case is STAMP. It's probably going to be easy to explain rather than try and just highlight why I'm using an individual one, and rather than argue why I'm using STAMP rather than FRAM, because they're very similar in a lot of ways. So it's beginning to strike me. Both STAM and FRAM have functional units. Both describe complex adaptive systems. Both have operator mental models versus work as done versus work as imagined. I don't like work as imagined as terminology. So do we need to sell non-linear modeling as a whole rather than burn resource time in explaining and justifying individual models for investigation as a group involved? And do we still need more industry-specific models when we still can't communicate our current models to those outside quality assurance? Because I'm moving to another organisation and the first thing they're saying to me is, oh, we need something that's specific for, so we need to adjust STAMP and CAST that makes it more medicine specific. I'm wondering if we're shooting ourselves in the foot. So it still comes back to this. All models are wrong, some are useful. And that's essentially the end of my talk. And I'm sorry if I've gone over time.